consolidation that persists after treatment of an acute process, okay? And we all learned as medical students the differential of blood, pus, and water when you have a patient with an acute chest x-ray finding, okay? But that unfortunately will not be an adequate differential for a patient who has a chronic airspace process. It's less likely to be blood, pus, or water, although still possible. And the possibility of cells, protein, and inflammation goes up. And the first thing that you want to do when you're looking at a chronic airspace process is classify the appearance. And here I'm talking about what finding do you see? Is it more of a dense consolidation, or is it more of a ground glass opacity, or is it more of a nodular or interstitial? And in this particular talk, I'm going to be focusing on these two abnormalities, consolidation and ground glass. But I should mention that I'm going to give you a short list of a differential diagnosis for both chronic consolidation and chronic ground glass opacity. But you should know that this differential that I'm going to give you is not a comprehensive one. It's a very useful one, and it might get you, 80% of cases that you'll see, but it is not by any means completely comprehensive. Okay, so let's start with chronic consolidation. And here I have a few warm-up questions for you. Okay, so the first warm-up question is going to be based on this image here. Baseline and 1 year, and then in the left lung, baseline and 1 year. Okay, and this is what it looks like. So which of these is most likely? Okay, so most people said tumor, and then it looks like the rest said organizing pneumonia, sarcoid, and then pneumonia is the last. Oh, hemorrhage is the last place. So we'll come to the answer in a little bit, but I'll tell you that tumor is not the correct answer, and I'll show you what the correct answer is in a bit. Okay, how about this question? Which of these is an atoll? Okay, most people said D, this is an atoll, but a good minority, 41% or so, said C is the correct answer. Not too many people said A or B. And again, I'll come to the answers, but these are just some warm-up questions to have you thinking. Okay, and here's kind of a different kind of question. You have to put on your clinician cap here. What are this person's symptoms? We have baseline and 1 year follow-up. It's kind of a tricky question. I'm being a little bit tricky here. Okay, most people said hemoptysis, and notably 0% said constipation. And so I'll tell you what the right answer is in a little bit, okay? Okay, let's come to our differential. The first thing that I have in this differential is sarcoid. And this is a multi-system disease with deposition of non-caseating granulomas. We don't really know what causes it, and most of the morbidity and mortality is from lung disease, but many patients are asymptomatic. And we know the classic chest x-ray finding of hilar and paratracheal lymph node enlargement, and then you might on the chest x-ray see perilymphatic nodules. But, and this is the classic chest CT appearance, by the way. Oh, let me go to the questions here. Okay. So this is the classic appearance of sarcoid on CT, where you see multiple tiny little nodules, and they have a perilymphatic distribution. And I really like to use the sagittal images for sarcoid because it really very well demonstrates the nodular studding of the minor and major fissures that you have in a classic appearance of sarcoid. And then if you also look on these axial images, you'll see that there's calcified lymph nodes in the hilum. Now, what does that have to do with chronic airspace disease? Well, sometimes those tiny little nodules can coalesce into a larger, what appears to be a mass-like consolidation. So in this case, you could see that this mass or consolidation is chronic. It has been there for at least a year, probably longer. And on the left side, there's another conglomeration of nodules here that is stable for a year. And how do I know that this is sarcoid? Well, the way I can tell is that if you look at the periphery of these lesions here, you can see that it's made up of tiny, tiny little nodules. Whereas a consolidation is typically, it might fade off into ground glass opacity. But in this case, you could see that the periphery are many tiny nodules, and the mass, therefore, the mass is a conglomeration of multiple small nodules. There's another finding that you might see in sarcoid that is similar, and it's called a pseudoplaque. A pseudoplaque is when you have a conglomeration of perilymphatic nodules along the fissures or pleural surfaces, and it mimics a pleural plaque. And it's the same phenomenon that's happening here in the middle of the lung that will happen in the subpleural part of the lung. Okay, and some people call this the galaxy sign, or some people call it, quote, airspace sarcoid, even though it does not involve the airspaces. So this is one of the things that can mimic a chronic airspace disease, or it technically is a chronic airspace disease because it's a chronic consolidation. So this is sarcoid. Okay. All right. So yes, and I mentioned another manifestation is that you can have air trapping. A good minority of patients will have air trapping, and so you may not see those patients have perilymphatic nodules, as in this patient. This patient had expiratory air trapping. Okay, yes, is there a question? Let's see, view. If you put your question in the chat, I will go ahead and take it at the very end. Okay. All right. Okay. Let's move on to the next topic, which is organizing pneumonia. This is a response of the lung to injury, and what you have pathologically is granulation tissue that collects in the alveolar ducts, and inflammation occurs in the interstitium. And it can be due to a number of different processes. And the CT appearance, the classic description is peripheral and peribronchial consolidation, but it can have multiple different appearances, like this perilobular pattern here, where you have thickening of the interlobular septa and kind of ground glass in the middle. You can also have small, ill-defined pulmonary nodules. You can have large nodules and masses, and you can have the atoll sign. So this is the atoll over here. The atoll is simply an area of consolidation at the periphery and ground glass opacity in the middle. Okay, so over here, we have a perilobular pattern. And this patient at baseline had these ground glass opacities and in the periphery. And at 1 month, you could see that they're still there. They may have changed a little bit, but they're still there. Here's something that you might see in a patient with cancer and radiation. So this patient had a tumor in their left upper lobe, And this was 1 week after radiation, just a bit ground glass opacity. And then 1 month later, you could see that there's extensive consolidation, both in the area that received the radiation as well as in the contralateral lung. One of the things that you can get from radiation is areas of lung that did not receive direct radiation can have organizing pneumonia in it. And you could see it 2 months later, it's not completely gone. It's still there. There's a lot of ground glass. It's maybe decreased in density, but a lot of it is still there. So the point is, you could mention that this could be pneumonia here in the 1 month study, but at 2 months, unless the patient's immunocompromised, you should really have resolution if they've been treated properly. And so at this point, you would bring up pneumonitis or organizing pneumonia. Okay. And here's another patient. So this is another appearance that you can see with organizing pneumonia. You can have one area where there's consolidation, and then on the subsequent exam, that area can go away or significantly improve. So we have ground glass opacity in that area of lung, but a new area of consolidation. So this consolidation was migratory. And then 2 months after that, you could see that that previous consolidation went away, but another area of consolidation formed. Okay, so these can be migratory as well. Okay, and this was the question that I asked you in the beginning. So this was the atoll, where you have consolidation around the periphery and ground glass in the middle. This is a CT halo sign. C is, so this is when you have the consolidation in the middle and the ground glass on the outside. Okay, and this you can see with things that cause bleeding in the lung, like angioinvasive aspergillus or vasculitis or metastases that can bleed. B, this was a teratoma in the mediastinum. You could see that this is a large fat-containing lesion, as well as containing calcification and soft tissue elements. So this was a mature cystic teratoma. And then A, this is simply a cavity. Okay, this is a cavity. I forgot exactly why, but I think this was a cavitary necrotic pneumonia. Okay. All right. Let's keep moving. Okay, it's important to know that the atoll sign, when you see it, it's closely associated with organizing pneumonia. So if you're already thinking organizing pneumonia and you see the atoll sign, that's probably what you have, but it's not pathognomonic. You can have lung cancer, you can have pulmonary infarcts, and you can have mucor that can look like that. Okay, and this was the question that I asked you in the beginning, the third one. What is this person's symptoms? And I can see that somebody answered the question in the chat here. They said paraffin. Oh, I don't know what happened to it, but yes, somebody said like paraffin constipation. So the answer here was constipation, and this person was taking mineral oil or castor oil for constipation. And what can happen is that mineral oil can coat the back of your lungs. So even if you don't frankly aspirate, when if you take it before you go to sleep, it coats the back of your throat, and you lie down and go to sleep, and you silently aspirate little bits at a time. And many people with chronic constipation, they take mineral oil every night. And so after a long time, it can collect in the lungs. Yeah, so it's accumulation of lipid material in the alveoli and alveolar macrophages, and it's usually from exogenous aspiration, as I mentioned, but it can be endogenous from proximal obstruction. There's something called golden pneumonia, where you have a proximal tumor and then fatty degeneration of a post-obstructive pneumonia. I don't think that's very common, though. Usually when you see fat-containing lesions in the lung, it's lipoid pneumonia, and it's usually from exogenous. And the CT appearance can be single or multiple areas of consolidation, and it can be mass-like. It can look like a tumor with spiculations. And the observation of macroscopic fat is helpful if you see it. Unfortunately, it's not always seen. And you can have also a crazy paving appearance with lipoid pneumonia. Also, you should note that lipoid pneumonia is not very common. Okay, but if you read chest, you'll see it. You'll see it from time to time, but it's not a common process. So here's the patient who I showed at the beginning. This was them at baseline, and you can see that 1 year later, this really hasn't changed that much. In fact, maybe it's gotten a little bit bigger. And the key is, if you're suspecting it, to put it on soft tissue windows. And you can see that in the middle of the lesion, there is low density material, which represents macroscopic fat. Okay. Now, the key is to remember to put it on soft tissue windows. Okay. And one clue is, even if you're looking at it on lung windows, you can faintly visualize that there's some areas of low density centrally. Now, one important caveat here is it has to be a dense consolidation if you're trying to find the macroscopic fat. Okay. If it's ground glass opacity, you can't put it on soft tissue windows to look for that fat, because the ground glass opacity will average with the lung, and it will give you something that looks like this, but it's not actually fat. It's just volume averaging. Okay. So, and the other second thing is, you can't. It's important to look at in the middle of the lesion. If I were on the edge of the lesion, again, I might be volume averaging with the normal lung, which will give me an artifact. Okay, so this was lipoid pneumonia. And here's another example that, in this patient, you can see it's very spiculated. And so initially the practitioners and the clinicians thought that this was a lung cancer, and rightfully so, because it looks very spiculated. But fortunately, it was benign. And this was lipoid pneumonia, which you can see on soft tissue windows. And as I mentioned, you don't always have to see the fat, okay? If you have a very good history of a mineral oil or castor oil ingestion, and you have these chronic opacities, that is sufficient for you to suggest the diagnosis. So here, this patient had ground glass opacity with some areas of septal thickening. You might call it crazy paving in some areas, and it was chronic. This is not the best image because of noise, but you could see that it's chronic. And so this was a lipoid pneumonia. Okay, same thing here. Some areas of ground glass, some areas of consolidation. Okay, another thing in the differential is atypical pneumonia. So this is simply pneumonia that is not a community-acquired pneumonia. And one thing to think about in this differential, well, two things really, is mycobacterium, which I believe you all have more experience with mycobacterium than I do here in Houston, Texas. But the second thing is endobronchial obstruction. Okay, let me show you some examples. So this is a patient who had a fungal infection. They had one of the endemic fungal infections, blastomycosis. And here they are at baseline. And you can see after treatment with antibiotics for community-acquired pneumonia, the consolidation did not go away. And they biopsied it, and it was blastomycosis. So they actually did a lobectomy. And unfortunately, it spread to the other lobe. And so there was persistent consolidation in the other lobe. And finally, they got it treated, and it went away, but it left some scarring in the lung. Okay. And here's another patient with a consolidation in the right upper lobe that was persistent after treatment with antibiotics for bacterial infection. And it looks like a big consolidation. Blastomycosis is common here in the United States. So is histoplasmosis, which is also common. Between the two, blastomycosis is more likely to look mass-like, like this, rather than histo, which is more nodular, small nodules rather. And then at 6 months, you could see there's an area of bronchiectasis. And here's another patient, baseline, and then 5 months after antibiotics, persistent consolidation there. Now, this patient did not have blasto. So this patient had an endobronchial obstruction from a carcinoid tumor. And if we go back, it's subtle, but you can see there's a very faint nodule right here in the right infrahilar region. So my take-home point for this particular study is that if a patient has and it's a relatively young patient, okay, let's say it's a relatively young, otherwise healthy patient, has a consolidation or a pneumonia in the exact same place on two separate studies, separated in time, then that should make you think that there might be an underlying structural abnormality, maybe a bronchostenosis or maybe an endobronchial tumor. And in this case, it was an endobronchial tumor from carcinoid. Okay, so that's atypical pneumonia. The next is round atelectasis. So round atelectasis is a special category of atelectasis. And it happens because of some abnormality in the pleura that results in a swirling of the lung parenchyma. And it's frequently associated with asbestos-related pleural disease. And what happens is you have this, on CT, you have these four things: a round area of collapsed lung. That area of collapsed lung abuts the pleural surface. And you have pleural thickening or effusion. And then you have volume loss, and then architectural distortion, so a comet tail sign, okay? So the kind of the four things you need are volume loss. The area of volume loss must touch the pleura. The pleura must be abnormal. And then you have architectural distortion, those four things, okay? And if you have contrast, this enhances like atelectasis, meaning it's going to enhance uniformly. And this is something common that you see, okay? And here's a nice graphic that shows how it happens. This patient has a pleural effusion, okay? And it pushes the lung up. And then over time, a little bit of scarring might form in the pleura and in the adjacent lung. And then when the pleural effusion goes away, that little bit of scarring will tether the lung in its place and cause that swirling appearance to form, okay? So the differential diagnosis is lung cancer. That's always something you want to think about when you have a round chronic opacity, a pulmonary infarct, and pneumonia. And let me show you more examples here, okay? So we have baseline, 6 months, and in soft tissue and lung windows. And yeah, so you have a round area of lung volume loss. We know that it's volume loss because this is the major fissure, which is pulled way down, okay? And then we have abnormality of the pleural surface. We have thickening of the pleura. Not only that, but the extrapleural fat is expanded. Look at the extrapleural fat here compared to the other side. This is the extrapleural fat right here. And compare that to this side, which is very thin. When you have expansion of the extrapleural fat like this, that is a very good sign that the process that you're looking at is chronic, okay? Okay, and this is a person with asbestos-related pleural disease. You could see the pleural plaques right here on soft tissue windows, and here's a pleural plaque along the fissure. And yeah, this person has these round areas of volume loss in both lungs. And it doesn't, in patients with asbestos-related pleural disease, frequently they're not completely round like this. Like they can be like linear or curvilinear like this. And this is, it's, you know, you may not call this round atelectasis, but it's essentially the same process that is happening with round atelectasis, even though it's not completely round. Okay. Okay, and here's another one. Here's what it might look like on chest x-ray. So here's a patient who had a baseline pleural effusion, and already you can see this kind of rounded opacity right here. And after a pigtail chest tube placement, you could see that the pleural effusion significantly improved, but they still have this round opacity right there. And then here it is posteriorly here. Okay, so that would be round atelectasis, and on CT it was right there. Okay, and notice the swirling appearance of the vessels going into it. Okay, okay, and then let's move on to the next thing in our differential, which is cancer. And there's two cancers I want you to remember. when you have a chronic consolidation. One is mucinous adenocarcinoma, and this is a subtype of adenocarcinoma that has mucin production. And on CT, it looks like a chronic progressive consolidation. It can have air bronchograms. It can also be multifocal with some areas of ground glass opacity, and it can also present as a mass or nodule, not always a consolidation. And mucinous adenocarcinoma is not rare, but it's not the most common either. Okay, so you'll see it from time to time. And frequently, the way these patients present is they'll have a consolidation on chest x-ray. The patient will be treated for pneumonia and it won't go away, and then they'll get a CT. And here's a patient who had interstitial lung disease. They had NSIP, and I think that was due to connective tissue disease. But in the right lower lobe, there was a more dense area of consolidation. And initially, we thought maybe this was a pneumonia. And so we said to follow it up. And at about 2 months later, you can see that it is still essentially unchanged. And at 3 months, it was still unchanged. Okay, so here in this case, at 2 months, I would raise the possibility that this is a cancer. And this is another one. So see, you can see it looks very much like a consolidation secondary to pneumonia with ground glass opacity, consolidation. And at 4 months, none of it seems to be getting better, okay, which is an important way to differentiate it from a pneumonia. In a pneumonia, let's say it's partially treated, some of it should be getting better, at least a little bit of it. Whereas in this case, all of it seems to be getting worse. Okay, and just another case showing it more of a mass-like appearance. Same thing. Okay, so that was the first cancer I want you to think about when you have a chronic consolidation. The second one is pulmonary lymphoma. And pulmonary lymphoma is essentially lymphoma in the lung, and it can be nodules, masses, but the kind of classic description in textbooks is consolidation with air bronchograms, and it can also be alveolar or interstitial opacity. Okay, so here is an example, baseline and at 1 month. So you can have pulmonary lymphoma be primary, and that's a primary pulmonary lymphoma is when the initial manifestations of lymphoma are in the lung. And then you can have secondary, where it involves multiple areas of the body, and then secondarily involves the lung, either with masses later on, or direct extension from a mediastinal mass. And yeah, you could see, like, it looks like kind of a CT halo sign. So on this baseline, you might be thinking, well, this might be angioinvasive aspergillus, or perhaps it's a primary lung adenocarcinoma. And at 1 month, it didn't change. Okay, so that makes aspergillus kind of go down on the list, and other infections go down on the list, because a fungal infection like that should get significantly bigger or smaller if it's treated. But at 1 month, no change. So I'm thinking it's cancer or lymphoma. Okay, and here's another one, baseline. And at 5 months, this one significantly improved, but didn't quite go away. And yes, this is the kind of classic appearance where you have a consolidation with air bronchograms like that. And here's one that's more mass-like. Notice how well circumscribed it is, right? Like most pneumonias that you see will not have so well circumscribed borders. Usually you'll have some ground glass at the periphery of a pneumonia. Okay, so that's lymphoma. Chronic eosinophilic pneumonia is one of the other things to think about when you have a chronic consolidation. This is one of the eosinophilic pneumonias, and if you're not familiar with eosinophilic pneumonias, it's a kind of it's a term that we use, but it's a collection of opacities, or it's a collection of diseases that are not necessarily related to each other, except for the fact that they have some kind of lung opacity and some kind of eosinophilia, either in the lung or in the peripheral blood. Okay, But chronic eosinophilic pneumonia is one of the eosinophilic pneumonias. There's also acute eosinophilic pneumonia. There's ABPA. There's Loeffler's. There's many different ones, but they're not necessarily related to each other. Like acute eosinophilic pneumonia does not necessarily turn into chronic eosinophilic pneumonia. And it's chronic eosinophilic pneumonia is frequently associated with patients with asthma, and patients will have eosinophils in the BAL fluid. And the classic description of chronic eosinophilic pneumonia is the photographic negative of pulmonary edema, where you have consolidation in the periphery of the lung rather than in the central part of the lung where you might have pulmonary edema. Okay? Again, so this is a classic appearance. Peripheral, upper lung predominant consolidation, aka the photographic negative of pulmonary edema. And here's one that was more of a ground glass in appearance. Okay, so that was my differential for chronic consolidation, okay? So remember, once you have a chronic consolidation, move past blood, pus, and water, and then move into this differential. I use the term space V, okay? S is for sarcoid. P is for pneumonia. So that means organizing pneumonia, lipoid pneumonia, and atypical pneumonias, like mycobacterium or fungal. Round atelectasis for A. C is cancer, pulmonary lymphoma, and mucinous adenocarcinoma. E is eosinophilic pneumonia, so chronic eosinophilic pneumonia. And then V, I didn't talk about because it's a whole separate lecture unto itself, but V is vasculitis, okay? Okay, so let's now talk about chronic ground glass, and I have a couple warm-up questions for you. This part is gonna go a little bit faster. Okay, most people said DIP. What was this person exposed to? Okay, most people said pigeons. Which organ has failed? Okay, most people said kidney. Okay, let's go on and wrap this up. So this differential that I'm about to give you is more for chronic ground glass opacity. The previous one was for chronic consolidation. And I'll just say that this differential for chronic ground glass opacity is, I don't think, as useful as the chronic consolidation, because ground glass opacity can be so many different things, right? So this differential is a good few things to think about, to remember when you have a patient with chronic ground glass, but it's certainly not a comprehensive list, okay? And one of the first things to kind of look up in the history is the patient a smoker, okay? Because then you want to think about the smoking-related lung diseases, respiratory bronchiolitis, and desquamative interstitial pneumonia. So respiratory bronchiolitis, or RB, it's a smoking-related lung disease where you have macrophages accumulating in the air spaces, and you have these tobacco-laden or pigment-laden macrophages. And it's very common on pathology, even though some patients may not exhibit signs on radiology. And what you're looking for are very faint kind of ground glass opacities that tend to be in the upper lungs of a smoker, okay? And this is common, okay? So if you see patients who have a smoking history, and or if you are seeing them for lung cancer screening, this should be something that you're looking for. You can see it's very faint. Okay, so it's really something that you have to think about and keep in your mind, and then correlate with the history. And then oftentimes it's helpful to narrow the windows so that it will demonstrate the ground glass opacity a lot better. Okay, so the differential is hypersensitivity pneumonitis, infectious bronchiolitis, and metastatic pulmonary calcification. But I'll tell you that respiratory bronchiolitis is generally much more faint compared to these entities here. And this question that I asked you in the beginning, this is where you have more diffuse ground glass opacity. And I'm not showing you the upper lungs here, but this is a patient, this is a CT of the lower lungs. And this is a patient who had DIP. Okay. So this is similar pathologically to respiratory bronchiolitis, except the disease is worse, it's more widespread, and the patients are usually older and a little bit more heavy smoker. And for the radiologic perspective, RB tends to be upper lung predominant, whereas DIP tends to be lower lung predominant, and you might see additional findings like subpleural reticulation, and you might see small cysts like you have in this patient. And whereas RB is pretty common, DIP is not that common. Okay, and here's another person with, this patient had these chronic ground glass opacities in their lower lobes and superimposed cysts. Okay, you can see it's kind of patchy in this other patient. Okay, so the smoking-related lung diseases, RB and DIP, pulmonary alveolar proteinosis. This is an alveolar filling with proteinaceous material, and it's secondary to accumulation of macrophages and surfactant in alveoli, and it can be primary or secondary, and most patients are smokers. And what it looks like here is ground glass opacity and superimposed interlobular and intralobular septal thickening. And this was a patient who had ALL and a stem cell transplant. And patients with the leukemias, pulmonary alveolar proteinosis is associated with that. It can also be associated with HIV, inhalational exposure, and immunosuppression with stem cell transplant. So radiologically, it can be ground glass opacity, it can be consolidation, and it typically has a geographic distribution. But note that PAP is rare. Okay, let's keep moving. Yeah, so this is the classic appearance of it, where you have ground glass opacity and superimposed interlobular septal thickening. Okay, and this is probably, if you're going to get pulmonary alveolar proteinosis on an exam, then most likely it'll be shown as a crazy paving appearance, because that's what's most closely associated with it in textbooks. Okay, here's a crazy paving appearance. Okay, moving on. Hypersensitivity pneumonitis. This is a lung reaction to an organic antigen, and it's usually an inhaled organic antigen, and it comes in fibrotic and non-fibrotic forms. And what I showed you in the question earlier are these diffuse centralobular ground glass nodules, and so this is a patient that did not have fibrosis, so this would be called non-fibrotic hypersensitivity pneumonitis. One of the other signs that you might see is called the 3-density sign, where you have areas of hyperlucent lung from air trapping. You have areas of relatively normal lung, like a few areas perhaps right here or maybe right here, and then diffuse ground glass opacity from inflammation. Okay, metastatic pulmonary calcification. Metastatic pulmonary calcification is deposition of calcium in the lungs from a patient with hypercalcemia, and it's usually seen in patients with chronic kidney disease. And the classic radiologic appearance is upper lung predominant central lobular ground glass nodules. And over time, initially those ground glass nodules won't necessarily be calcified, but over time, they will, as that calcium deposits, you will see the calcification. And it can involve the septa, bronchi, and arteries as well. And so this is a patient who at baseline, you can see their central lobular ground glass. We know they're central lobular because they're sparing of these interlobular septations and the pleural surface. And after 6 months, you could see that those have really increased in density, and you can see the calcification much better. Okay, so that is my chronic ground glass opacity differential. I don't have a fancy mnemonic like I did for chronic consolidation, but remember to think of the smoking-related lung diseases, respiratory bronchiolitis, and desquamative interstitial pneumonia, pulmonary alveolar proteinosis, hypersensitivity pneumonitis, which, by the way, if a patient is a smoker, that usually has a slight protective effect against hypersensitivity pneumonitis. Okay, so both of these, respiratory bronchiolitis and hypersensitivity pneumonitis, can have central lobular ground glass nodules. I mentioned that respiratory bronchiolitis, the ground glass nodules are more faint, but also if they're a smoker, that's less likely. They're less likely to have hypersensitivity. Atypical pneumonia again, and then metastatic pulmonary calcification. Okay, that is it for me. If you'd like more educational content on chest radiology, definitely, as Akshay mentioned in the beginning, visit my my YouTube videos, or there's some awesome educational content from the STR website. They have great videos for all education levels on chest radiology. Okay, let's go to the chat here. Okay. Is a differential of sarcoid considered in a history of gradually progressive shortness of breath over 5 to 6 months? Yes, that could be the case. Sarcoid, most patients with sarcoid, if they have symptoms, will present with shortness of breath or cough. They may also be asymptomatic, but yes, a patient with progressive shortness of breath, sarcoid is certainly in the differential. Mediastinal lymphadenopathy, including enlarged prevascular, pretracheal, paratracheal, no bilateral hilar. That's uncommon, but it's not unheard of. So the classic appearance is bilateral hilar lymphadenopathy. But if you don't have hilar lymphadenopathy, but you have mediastinal, you could still have sarcoid. I would be a little bit more suspicious of it, that it could be some other process like malignancy, but it could still be sarcoid. Do these differentials also apply in pediatric cases? I don't do pediatric, but certainly for, so sarcoid is not super common in the pediatric. The organizing pneumonia, yes. Atypical pneumonias, yes. Lipoid pneumonia, no, not really. Round atelectasis, yes. Cancers, so pulmonary lymphoma, not very likely. Mucinous adenocarcinoma, no, not very likely. And then chronic eosinophilic pneumonia, I don't know how common chronic eosinophilic pneumonia is in the pediatric age range. Okay. So some of them, yes, some of them don't apply. Okay. Oh, I appreciate that. Oh, Vimal Raj, I need to look that up. I'm not familiar with him. Okay, from Peru. Well, welcome. Is there any feature between pulmonary infarct and peripheral pulmonary lymphoma? Yes. So both of them on initial presentation may show up as a peripheral area of consolidation, but there's going to be a couple different features that are different. One is that the classic description of a pulmonary infarct is one in which you won't have air bronchograms, okay? Classically, the pulmonary infarct will not have air bronchograms. It might present as a peripheral consolidation or ground glass, and it's typically wedge-shaped. but no air bronchograms, where the classic description of a pulmonary lymphoma is with air bronchograms. And then also the pulmonary lymphoma, not usually wedge-shaped. It can be. It can be consolidation that was wedge-shaped, but it doesn't have to be. Whereas a pulmonary infarct really is wedge-shaped because it goes in a distribution of the blood supply. What's the difference between silicosis and sarcoid? Nodal calcification more common in. So probably calcification is more common, particularly eggshell calcification with silicosis. But I'll tell you that they can be indistinguishable from each other. Okay, so if you have something that looks like sarcoid, but the patient works with sandblasting or works with countertops, then I would think along the silicosis route. In my population, I see sarcoid way more commonly than silicosis, but it's highly variable around the world. Sarcoidosis is common in African American patients, so it may not be common in areas where you have silicosis may be much more common in some other areas. Okay. Any other questions?
Actually, there are some questions in the Q&A.
Oh, Q&A. Okay, yes. Peripheral waxing and waning cannot be eosinophilic pneumonia. So there are other kinds of eosinophilic pneumonia, not chronic eosinophilic pneumonia, that have a waxing and waning appearance. That can be like not acute eosinophilic pneumonia. It's called Leffler's or simple eosinophilic pneumonia. That can have a waxing and waning appearance. Chronic eosinophilic pneumonia typically does not. How to differentiate DIP from hypersensitivity pneumonitis? Okay, so there can be overlap. One is the history, because smoking will be more common, of course, in DIP, and it'll be less common in HP. But there definitely can be overlap because you can have areas of air trapping in patients who are smokers from their bronchitis. So I'll tell you that if you have a patient with relatively diffuse ground glass and mosaic attenuation, and you're having trouble distinguishing, that might be a patient in which a biopsy can help you. Okay, because there can be quite a bit of overlap. Now, if you see a kind of dense centrilobular upper lung predominant ground glass nodules, I'm thinking hypersensitivity. If you see other signs of smoking, like emphysema, or you see those cysts in the lower lungs, like in DIP that I showed you, then I would be thinking more DIP. But in this PowerPoint, I showed you kind of classic cases. Out there in the real world, as you know, they're not always this classic, so it can be difficult to tell. But pathology is very good at differentiating the two. Okay, next, how to differentiate the infectious lesion versus METS versus primary lung cancer. Okay, so in general, primary lung cancer will be a spiculated lesion that'll get bigger over time. Infection should go away, at least partly, in a short time interval, okay? And then also, the other thing with infection, if it grows very fast, like in 4 weeks, it has doubled or tripled, okay, that is more likely infection, whereas lung cancer will not grow quite that fast. And then METS, usually for METS, there's going to be multiple nodules, and they tend to not be spiculated. They tend to have a smooth contour. Do you perform routine expiratory phase CT? Yes. On patients with HRCT, we do it. On just every patient, no, we don't. So if you are thinking that the patient has any kind of air trapping, that's when you do it. Like if you have a stem cell transplant and you're thinking that patient has bronchiolitis obliterans from graft versus host disease, that would be an indication. If you're thinking hypersensitivity pneumonitis, that would, or any interstitial lung disease, typically we do expiratory. Are smokers less likely to develop hypersensitivity pneumonitis? They are. They do have a less, I'm not sure why, but they do have some protective effect of smoking. Of course, that's not an endorsement of smoking, but yes, they do. Can there be a miliary nodular pattern in pulmonary eosinophilic syndrome? I have not seen that. That to my knowledge, no. To my knowledge, no. Can dog ownership lead to hypersensitivity pneumonitis, or is it rather due to birds? Well, I don't know about dogs, but I know that birds have a very, very good correlation with it, and it's due to some kind of mold that grows in their droppings. I don't think dog ownership has quite that relationship, although I might be wrong there. Can one make the diagnosis of COPD on CT, or is it only a clinical diagnosis? Well, we don't use that term in radiology of COPD. We say chronic bronchitis or emphysema. And so really it's a clinical diagnosis, but we could certainly make the call of chronic bronchitis if the patient has chronic bronchial wall thickening. Like on 2 separate CTs, you see bronchial wall thickening 3 months apart, then I would say chronic bronchitis. And if they have, emphysema, central lobular or paraseptal, that we can make that call too. So it's a clinical diagnosis, but you can see the findings. I don't say COPD in my report. Does using mosaic attenuation, I'm not sure what this question means. Does using mosaic attenuation? Okay, if you're still here, can you retype? I'm not sure what this question means exactly. How to approach consolidation mass in lung detected on baseline? So it depends on kind of the risk factors, and I live in a place where TB is not very common. Okay, so if you live in a place where there's a high chance of having TB, then it may not make sense to go straight to a biopsy if you see a mass, right? It may make more sense from a prevalence standpoint to do an induced sputum and look for TB. What we do usually, though, if you see a consolidation in mass and it looks like a cancer, like a lung cancer, we send them for further testing, like biopsy. Now, if it's more of a consolidation, like that mucinous adenocarcinoma I showed you, then we usually treat those as infection, and if it doesn't go away in 4 weeks, we proceed further with biopsy. Is primary lymphoma a confident imaging diagnosis? Not really. It's something I would suggest, but we usually get tissue. In pregnant females with pulmonary embolism, what is preferred, CTPA or ventilation perfusion study? Okay, if a patient has symptoms of pulmonary embolism, the first thing I would probably do is a lower extremity ultrasound. And if that's positive, I would just treat, and then you don't have to do any radiation. If it's negative, then I tend to do a CT because I think it's a little bit more definitive, and then it can also show you other things that might be the actual cause of symptoms, like a pneumothorax or a pneumonia. And you should know that the radiation that is delivered to a fetus is significantly lower than what the lung gets, because we have it. The radiation is inversely proportional to the square. It's like the inverse square law. It's inversely proportional to the distance from the source. So the amount of radiation that the fetus is getting is actually kind of low. When to give contrast, anytime you are concerned about the mediastinal lymph nodes, or the vasculature, like for pulmonary embolism. If you're just concerned about the lungs, it's not really always necessary to give contrast. Okay. Anything else?
I think that answers all the questions. Rishi, this was a fabulous session with such a wonderful approach to a very complex topic, I would say. And lovely images, and I think the opinion poll, the poll we really set the tone. I think everyone really enjoyed that interactive portion of it.
Great.
Thank you.
Great. Yeah, I love doing those polls, and next time I can put in some more fun questions. But yeah, thank you for the opportunity to speak to you all. It was very fun, and it's cool hearing all your questions. And maybe we could do this again.
Absolutely, absolutely. And for those attending, I've put the YouTube link of Rishi's channel on the chat box as well. So please definitely have a look at it and subscribe to it. And I'm sure we will have you back again, Rishi, very soon. Thank you so much for a wonderful session, and wish you a happy rest of Sunday. And thank you to all the attendees as well.
Likewise. Goodbye.
Bye.